a quiet settles over the room as session 4 begins. Good late morning. I'm Tyler Hughes from the University of Kansas. And if you'll recall, Kansas is a state that gave you Ted Lasso. So I just want to say, appreciate y'all. How y'all doing today? Thank you. I'd like to remind you, as Ted would say, that we appreciate our sponsors, and we'd like you to go visit them before their exhibits close. Also, the Fortune Law Firm is going to feed us lunch at 12:30, which is voluntary. And as Ted Lasso would say, anytime a lawyer is giving me money or food, I consider it a much better experience than usual. So, without further ado, Tyler Hughes will come back and introduce the first presentation, which is textbook outcomes as a quality metric in living and deceased donor kidney transplantation from, I believe it's pronounced, The Ohio State University. The presenter will be Austin Schenk, MD, PhD. Dr. Schenk.
Good morning. I'd like to begin by thanking the Society for the opportunity to present this paper on behalf of my co-authors. We have no disclosures to report. 1 year of patient and graft survival following kidney transplantation now exceed 97 and 95%. Historically, patient and graft survival have been cornerstones of both quality and regulatory monitoring in transplant. Because almost all transplant centers now routinely achieve these benchmarks, these metrics fail to discern the spectrum of quality in the care provided to transplant recipients. Textbook outcomes are composite quality metrics that describe ideal outcomes following specific surgical procedures. Textbook outcomes are well developed in surgical oncology, bariatrics, and vascular, but have not been rigorously explored in transplantation. Our goals were to define textbook outcome following living and deceased donor kidney transplantation, and to then validate this definition in a large national cohort. We aim to identify the determinants of textbook outcome, develop tools for predicting textbook outcome at the individual patient level, and then appropriately risk adjust to evaluate textbook outcome as a center-level comparator. Our definition was formulated using multidisciplinary input from the kidney transplant team at our center. We used UNO-STAR files to obtain national data, performed multivariable selection using the technique of purposeful selection, and for risk adjustment used observed to expected methodology similar to that currently used by CMS and the Scientific Registry of Transplant Recipients. We included adult kidney transplant recipients and excluded multi-organ transplant recipients and patients retransplanted within 1 year of their index case. Our final cohort included 20,000 living donor recipients and almost 50,000 deceased donor recipients. 72% of the cohort had 5-year survival data available. Our composite definition of textbook outcome included patient and graft survival greater than 1 year, evidence of reasonable long-term allograft function as indicated by a 1-year GFR of at least 40, a hospital course free from delayed graft function in less than 5 days in length, and freedom from readmission during the first 6 months post-transplant, and freedom from rejection throughout the first year post-transplant. Textbook outcome was achieved in 54% of living donor recipients and 32% of deceased donor recipients. In both cases, prolonged length of stay was the primary reason for failure to achieve textbook outcome. Readmission and rejection rates were slightly higher in deceased donor recipients, and as expected, delayed graft function was the leading reason that deceased donor recipients failed to achieve textbook outcome. About 15% of living donor recipients and 25% of deceased donor recipients had a 1-year GFR less than 40. Definitions of textbook outcome are, admittedly, arbitrary, and therefore it is essential to correlate textbook outcome with a meaningful clinical endpoint. We chose 5-year survival and performed a conditional survival analysis in which achievement of textbook outcome was set as the conditional variable. The hazard ratio for death at 5 years is 2 for both living donor kidney transplant recipients and deceased donor kidney transplant recipients who do not experience a textbook outcome. In order to understand donor and recipient factors that influence textbook outcome, we performed multivariable logistic regression. Shown here are the 8 covariates with greatest impact on whether or not a living donor recipient experiences a textbook outcome. Odds ratios are shown, and p-values were used to rank order the variables with respect to their impact on the model. Older donor age has greatest impact and markedly reduces probability of TO. Recipients with functional status between 80 and 100%, as measured on the Karnofsky scale, have 2.3-fold increased odds of achieving textbook outcome. Etiology of renal disease factors in, and patients with hypertension, IgA nephropathy, or polycystic kidney disease have a better chance of achieving TO compared with patients with lupus or diabetes. Higher recipient BMI, lower recipient serum albumin, and recipient need for pre-transplant dialysis all reduce probability of TO. To our surprise, donor ethnicity significantly influences the model, presumably reflecting either HLA disparities in the donor and recipient gene pools or comorbidities with renal manifestations that are more prevalent in certain ethnicities. In deceased donor transplantation, where there is a wide spectrum of donor quality, donor variables are the strongest determinants of textbook outcome. The odds ratio for textbook outcome is 0.55 for recipients of a kidney from a deceased from cardiac death donor. Other factors that reduce probability of textbook outcome include higher kidney donor profile index, higher donor terminal creatinine, older donor age, and longer cold ischemic time. Recipient need for dialysis, number of years on dialysis, and higher recipient BMI also decrease probability of textbook outcome. We were surprised to find that if the donor kidney was subjected to hypothermic machine perfusion, the recipient had increased chance of textbook outcome with an odds ratio of 1.3. The same covariates with strong impact on the model were incorporated into nomograms that allow for prediction of probability of textbook outcome at the individual patient level. Our nomogram for deceased donor transplantation and the corresponding receiver operating curve are shown as an example. To complete our analyses, we considered all of the patients transplanted within the study timeframe at each individual transplant center. We calculated probability of textbook outcome for each patient transplanted at a given center to arrive at an expected mean center-level textbook outcome rate, which was then compared with that center's observed textbook outcome rate. After this risk adjustment, individual transplant centers can be classified as performing at, above, or below performance expectations. In the case of deceased donor transplantation, 26% of centers exceeded performance expectations, 50% performed as expected, and 24% were identified as underperforming. As shown at right, there was little correlation between total transplant center volume and center performance. Results were very similar in living donor transplantation. Our study has several limitations. First, this definition of textbook outcome was formulated by a wide range of clinically active transplant professionals at our center, but at present we lack national consensus on this definition. Secondly, there are certainly variables of interest that are not captured in the UNOS data set. Reoperation rates, presence or absence of a Foley catheter at the time of discharge, and need for transfusion, just to name a few. We feel this highlights an overall need for better data capture and transplant. Additionally, important aspects of the patient experience of transplantation, including waiting time and waitlist mortality, are not included. Though important, we deliberately chose to exclude these as we feel that these are not at present entirely within control of the transplant centers. Lastly, about a quarter of the cohort has not yet reported 5-year survival. However, due to the very large sample size, we doubt this will significantly alter our results. In summary, textbook outcome adds value to the current standards of 1-year patient and graft survival and is achieved by 54% of living donor recipients and 32% of deceased donor recipients. It is extremely important to note that in most cases, even when a textbook outcome is not achieved, the transplant recipient still receives an outcome that offers significant survival advantage when compared to life on dialysis. Because of this, we feel textbook outcome has great potential for quality improvement initiatives, but should probably not be co-opted for regulatory use. Kidney transplant recipients that experience textbook outcome traverse the smoothest course from operation to discharge and recovery and have superior long-term survival. Thank you.
Due to circumstances beyond your control, Dr. Erin Baynard cannot be here as invited discussant, but I will recite her discussion and try to do it justice. Thank you very much for the opportunity to review this paper, and she states she is sorry she cannot be there with everyone at the meeting this year. Congratulations to the authors. As alluded to in the manuscript, with the changes in reallocation and discussion of MPSCs, revision of national quality metrics, this study could not be more timely. I think it is well known within the transplant community that the measure of one-year graft patient survival is not really an adequate measure of quality, nor should it be what we are aiming to achieve in transplantation. However, it has been said, it has been the best we had. Given our data gathering practices, with that being said, I have a few questions. One, you seem to still have picked metrics that you were able to gather from the SRTR database. While this is a more comprehensive approach to data gathering and quality, you are still limited to the data previously gathered. If you were able to actually pick metrics that you thought were most valuable, what would they be? Such as Barbas and colleagues utilized different variables like intraoperative complications that are easier to capture at a single center. Second question. The follow-up question to that would be, how would you propose this data is gathered and captured moving forward? While easier to do at one center and with a retrospective review, tasking individuals at each center to input more granular data into a larger database would increase cost to each individual transplant center and likely would be prone to error. Third and final question. Lastly, do you propose we utilize the information that you have gathered moving forward? As in, how can we use this to modify MPSC proposal or reallocation? And she thanks us again for the opportunity to review and discuss this fine paper.
Well, thanks to Dr. Maynard for her thoughtful review. Her first question relates to the variables that were chosen for analysis. As I said, our approach was developed through multidisciplinary input from our transplant team, and we started with a very broad list that included a number of variables that were not present in the UNOS data set. So additional things that I think are important, I would give consideration to longer-term survival, to the rates of reoperation, but overall we sought to develop an approach that could be applied nationally, so we were constrained by the data set. I do take her point that asking the transplant centers to report more granular data will increase cost. However, just because many transplant centers are able to achieve excellent one-year patient and graft survival does not mean they're not obligated to also pursue the highest level of quality in the care of their patients. And so, to some degree, reporting and collecting this data is just sort of mandatory for good patient care. Can you remind me the third point?
Third point is, how would you utilize the information that you have gathered moving forward?
So, I think the greatest opportunity with this tool that we've developed is for individual transplant centers to benchmark themselves against peer institutions. So even if you're categorized as performing above expectations, you can still look within the individual quality domains of textbook outcome and find individual domains like length of stay or DGF rates in which you may be able to improve. So that benchmarking relative to peer institutions is probably the primary value of this. I do not think this has a role directly for use for regulatory monitoring, and that's primarily because it's well known that even times less than 1 year off of dialysis are considered advantageous for transplant recipients in terms of overall health. And so therefore, extending textbook outcome for regulatory purposes is probably not warranted.
Thank you. Dr. Brasley, you had a question?
It strikes me that although a lot of the characteristics and variables that were associated with textbook outcomes are not modifiable, not mutable, the one that potentially is putting the kidney on pump. And although I appreciate the reasons you're staying away from wanting this to be regulatory, that seems to be a modifiable practice that potentially could improve textbook outcomes that regulatory bodies might be able to help, not being in this area, but that struck me as a modifiable factor as opposed to donor age and some of the other things that you had.
So I agree. Some of the variables that are determinants of textbook outcome are non-modifiable, the health status of both donor and recipient, but two things that jumped out of the analysis that are modifiable. One, ischemic time has a significant impact on the model, and therefore, this has implications for allocation policy. How quickly can we get kidneys to transplant centers for implantation? So that is a modifiable variable. And then, as you suggest, machine perfusion. We surmise that use of machine perfusion leads to faster function of the kidney, earlier discharge from the hospital, and that's probably how it ties into the composite outcome of textbook outcome. Certainly that's a choice incurred by transplant centers, but they may find that they save on the cost. While it costs money to pump a kidney, if the patients are leaving the hospital sooner, it may be overall cost advantageous.
Is there further discussion from the floor? Seeing none, I thank you very much for your presentation and bringing your work here.
Thank you.
Our next presentation is residents versus attendings. Win, lose, or draw. Can residents perform minimally invasive cholecystectomies independently without compromising clinical outcomes? This paper will be presented by Dr. Kelsa Tonelli. I hope I came close.
You were, yes.
There we go.
There we go. Hello, my name is Chelsea Tonelli, and I'm a general surgery resident at Loyola University Medical Center. Thank you for the opportunity to present our work. Residents perform laparoscopic cholecystectomy with acceptable outcomes when provided with supervised independence. The contents of this presentation do not represent the opinions of the VA or the U.S. government. With increasing pressure on surgical faculty regarding efficiency and productivity, the introduction of new technologies and treatments, and time restraints such as dedicated education periods and the shift towards greater work-life balance, many are questioning whether general surgery residents are prepared to operate independently at the conclusion of their residency training. Data is lacking regarding the amount of graduated autonomy and supervised independence provided to residents during training, which led to our interest in this topic. Previously published, the Swish scale is a validated tool to assess the degree of guidance provided from the attending to a trainee during the most critical portion of a procedure. The scale includes 4 levels: show and tell, active help, passive help, and supervision only. These represent increasing levels of independence for the resident. With this established scale in mind, we developed our hypothesis that senior residents provided with supervised independence are able to achieve similar postoperative outcomes in a core general surgery operation. To evaluate this hypothesis, we look to examine patterns in supervised independence being provided to residents over time and its effect on postoperative outcomes. We utilize the VA Surgical Quality Improvement Program, or VASQUIP database, to explore these concepts. A laparoscopic cholecystectomy was selected given that it is a common general surgery procedure and one with which senior residents should be comfortable performing. We focused our analysis on cases performed for uncomplicated biliary disease, with other exclusion criteria listed below, including cases performed without a resident or with only a PGY 1 or 2. Utilizing the previously mentioned Swish scale, we created a comparison to the variables available in the VASCP database as seen here. The VASCP database provides information regarding whether an attending was scrubbed into a procedure or not scrubbed and supervising. We equated the Swish scale levels of show and tell and active help to the VASCP level of attending scrubbed in, which we will refer to as attending cases. Similarly, where passive help or supervision only were provided, were equated with cases where the attending was not scrubbed, and these will be referred to as resident cases. With this in mind, our selected outcomes of interest are listed here. We evaluated operative time, return to the operating room within 30 days, whether a post-operative complication occurred, and whether it was surgical or medical in nature, and if the patient was discharged to a facility. We performed a hierarchical logistic regression clustered by facility and one-to-one propensity score matching in our analysis. We identified 23,475 laparoscopic cholecystectomies during our study period, which had a resident involved. Of these, 20,268, or 86%, were performed with an attending scrubbed into the case, and 3,207, or 14%, were performed without the attending scrubbed in, but with their oversight. The attending cases had a median age that was older by 2 years and with higher ASA class. There were similar rates of cases performed on an emergent basis, and as would be expected, the majority of the cases performed with higher resident autonomy were done by the chief or PGY5 resident. Over time, there was a steady decline in the proportion of cases that were performed without the attending scrubbed in, indicating more direct involvement by the attending in more recent years. Since 2010, the proportion of resident cases has been mostly stagnant at 10%. On assessment of operative time, cases done without the attending scrubbed had longer operative times than those performed with the attending scrubbed. Although this is a statistically significant difference, the absolute magnitude of the difference in operative time was marginal, only about 3 minutes. Next, we performed a univariate analysis of our selected outcomes. There was no difference in overall complication rates, even when assessing whether they were surgical or medical in nature. There was a small but statistically significant increase in proportion of patients in the attending group who were discharged to a facility. This might indicate a more technically complex case or patients that were less healthy at the time of the procedure. To further evaluate these findings, we performed a hierarchical logistic regression. We clustered our analysis on each facility and adjusted for other factors listed below, including age, tobacco use, ASA class, and case urgency. We found that the residents having higher levels of independence was not associated with an increased odds of any of our selected outcomes. The difference was previously observed in discharge to facility is no longer seen here. To further assess these findings, we performed a one-to-one propensity score match using the variables listed below to create similar cohorts and adjust for factors likely to contribute to differences in outcomes. On comparison of these matched cohorts, cases done without the attending scrubbed remained statistically longer than those done with the attending scrubbed, although this difference was again not clinically significant at 4 minutes. There were no significant differences in rates of adverse events, including complications, whether surgical or medical, or surgical site infection. The higher rate of discharge to a facility in the attending cohort is no longer seen, suggesting that our matched cohorts have similar levels of complexity. Our study was limited by what was available through the database. There is selection bias in our study, given that the attendings will typically select technically easier cases for the residents to perform and are more likely to provide residents with higher operative skill, more clinical autonomy. We attempted but were unable to definitively control for the technical difficulty of the procedure. While we utilize the attending scrub status as a measure of resident autonomy, we cannot determine the amount of coaching or guidance that took place during the procedure. Finally, given the overall population of veterans represented, contains mostly older white males. This may limit the generalizability of our findings. Despite these limitations, we believe that our findings support our conclusions, that there are decreasing rates of graduated supervised independence in our surgical training model. Allowing residents to operate with greater levels of autonomy only prolongs the operative time slightly. Outcomes such as complication rate are not compromised by resident independence with appropriate oversight. Thank you again to the Western Surgical Association for the opportunity to present our work, and I welcome any questions at this time.
Our invited discussant for this is Dr. Jasmeet Paul. Dr. Paul.
Good morning. I'm Jasmeet Paul from Albuquerque, New Mexico. I'd like to thank Dr. Tonelli and her colleagues for providing me a copy of the manuscript well in advance. I'd also like to thank the program committee for inviting me to review this paper. I'll keep my comments and questions brief. Firstly, were there any common bile duct injuries or cystic duct stump leaks in either group? Those complications were not specifically addressed. Your data also suggests that the proportion of attendings that were scrubbed had increased from around 65% at the beginning of the study to almost over 90% at the end. What do you attribute this dramatic shift to? Are attendings really scrubbing in all these cases, or is this an issue with the way the data was initially entered in the early days of the VASCRIP database? And we all know that a lap chole is a team sport. You need 2 or 3 people involved with the operation. So when the attendings were scrubbed in, what was their role? Were they holding the camera, holding the fundus, or were they the primary operators? If they're not the primary operator, then they're probably giving oversight and general technical direction, which they could also do while they're not scrubbed in. And in many programs, senior residents act as teaching assistants for mid-level or junior residents for lap choles. Does the VASCRIP data capture residents operating together? If so, are the attendings less likely to scrub? All in all, this is a really important paper that shows that the level and extent of resident involvement in this common general surgery operation does not add significantly to the operative time or complication rates. I will be definitely taking this back to our quality officer, who is always talking about this subject. Congratulations on this work, and once again, thank you for providing the manuscript for review.
Thank you. Closing the paper by Zoom is Dr. Marshall Baker. Come in, Dr. Baker.
Good morning. Can you guys hear me okay? Great. We thank the Western for giving us the opportunity to present this work, and I appreciate also the deference of the group and allowing me to make these comments from a distance. And I appreciate Dr. Paul taking the time to review the paper and his insightful questions. I would say that in this case, as we often find ourselves in many of these type studies, we are trading in a big data analysis statistical power for granularity. And like Dr. Paul, we would certainly ideally have better information about things like bile duct injury and the level of attending involvement in the cases. Unfortunately, given limitations of the data set, we can't sort of get at that kind of information. So we don't know, how many bile duct injury actually happened. We don't know how many cystic duct leaks we actually had. We really can't tell, as Dr. Tonelli alluded to, what the attendings are actually saying when they're at the bedside scrubbed, what they're saying when they're not at the bedside and not scrubbed, or what they're actually doing when they're at the bedside scrubbed. We also can't account for the effect of multiple residents that are involved in the procedure. And we can't really control as much as we would like to for case complexity. Having said that, I think there are a couple of observations that we can make safely that have value to our community. Number one is that the opportunities for independence are declining and have continued to many years after the induction of the work hour limitations by the ACGME. We think that this reflects very likely that there are multiple factors that are driving this, many of them socioeconomic, that are making making it, or increasing the amount of pressure that attendings face with regard to their own productivity and their own efficiency, meaning that they are repeatedly asked to do more with less time. And we think this is probably affecting their ability to sort of give in the operating room. I think we can also safely say that an approach where you attempt to give the resident as much independence as is safe and reasonable is something that is safe and reasonable, meaning that the operative times are not that much longer when this approach is taken, and the complication rates are statistically identical. We fully recognize that many of the cases that the resident gets credit or that the attendant gets credit as scrubbed on probably involve cases that they started out not scrubbed and then take over. And so the time there may be shorter than would otherwise be. But I think the fact that, I think it still reflects the fact that if you allow the resident to have as much autonomy as they can have, you can keep the cases at a reasonable length of time and the complication rates in a reasonable window. We think this is data that really hasn't been presented in any way prior to now, and that it suggests that we ought to really be trying to work as hard as we can to preserve these opportunities for those trainees, as we all recognize that they are crucial opportunities in terms of developing proficient operators that graduate from our programs. Again, we thank the Western for the opportunity to present this work, and I again appreciate the deference of the group in allowing me to make these comments remotely, and we're happy to take any additional questions. Thank you.
Hello, yes, there we go. Thank you, Dr. Baker, and Dr. Sherry Wren has a question from the floor.
Yes, hi, Sherry Wren. I'm actually the chair of the General Surgery Advisory Board for the VA, so please take these comments with that in mind. The VA has actively gone to discourage resident autonomy. Starting I think a lot of us trained in the VA, and we sort of had that thing that this was like, a free-for-all, and your attending was the next best thing, long distance, you'd call them. So years ago, the VA actually mandated that the attending had to be in the room for the timeout. Talk about an absolute autonomy killer. You have to be present in the room. And now it's to the point where they look at the data, and if you are logging too many cases where the attendings are not scrubbed, you will get a site visit. And when you talk to the National Surgery Office, they really view this along the ethical line of that, that it's not right for the patients. People are residents are trainees. And so this historical view that all of us had of the VA that I trained in and everything, in many cases just does not exist anymore. So I applaud you on trying to put the data together, but there's so many things that aren't in there, and just to know that the political movement in the VA is not to encourage this. So I'd be curious to hear your thoughts on that.
Yes, Dr. Baker.
Yeah, I think we are aware of that and feel that, and we're not advocating, that the attending is not present or involved at all. But we certainly feel like it is a environment where, we can be more passive in a way that's appropriate and safe and important as a mechanism for allowing young doctors to develop. And I honestly think that we need to find a way to advocate for that. I am, as many in the audience will know, a very hands-on person. I get criticized for it all the time, but having transitioned into a more active role at the VA in Chicago, I think it's essential that we allow the trainees to have a certain degree of independence in the operating room, and I feel like it's safe and can be done in a way which is reasonable and high quality.
So as I say on the networks, Dr. Jarman, we have about 30 seconds left. Quick question, quick answer, please.
Thank you. So first, a plug for Entrustable Professional Activities, which are coming up, which hopefully will help us gain ground on this front with entrusting residents to do certain things, and then hopefully be able to come back to organizations and say, this is what we're doing. We need to do this to make sure they can practice on their own before they transition to practice. And number two is we've got about a 10-year history now at Gunderson reestablishing a chief service that's independent practice for the chief with appropriate supervision, with great outcomes and great patient care satisfaction. And actually, I think patients actually would rather see a resident through their continuity of care than an attending sometimes. So I think we have to use this as a call to action to reestablish chief level rotations that do have some autonomy built in where they have 100% continuity of care. And that can be done regardless of your system. So I think sorry, more of a comment than a question, but I'm just wondering what you plan on doing next if you have any time to respond along these lines.
Yes, we have just a few seconds. You get the final word, Dr. Baker.
I think that's a great question. What do you do? I mean, I will go back to our institution and do the best I can to try to give people a chance to do what they can in the operating room. And I think we should all do the same thing in our own environments. I also think we ought to be vocal about the need for supervised independence going forward. I mean, I can't imagine not having had it as a trainee and then having to start doing cases without having had that experience prior to doing it as an attending. I mean, I think it's just essential. We should speak up. I think we should be advocates. I think in doing so, we're being advocates for future patients.
Thank you very much. We're out of time, but it's always enough time to do the right thing. I hope we do in this case. Okay. Our next paper, number 16, is Plasma Resuscitation with Adjunctive Peritoneal Resuscitation Improves Hepatic Blood Flow and Reduces Evidence of End Organ Damage Following Hemorrhagic Shock. This is from the University of Louisville and will be presented by Dr. Jessica Schucht. Thank you very much.
Like you said, I'm Dr. Jessica Shook. I'm a resident at the University of Louisville Department of Surgery. And I'd like to thank the Western Surgical Association for allowing us to present our research. As he said, our project is entitled Plasma Resuscitation with Adjunctive Peritoneal Resuscitation, Improves Hepatic Blood Flow, and Reduces Evidence of End Organ Damage Following Hemorrhagic Shock. The authors have no conflicts of interest to report. Hemorrhagic shock is the leading cause of preventable death following trauma. The mainstay of treatment, as we all know, is restoration of circulating blood volume and central hemodynamics. However, the restoration of central hemodynamics does not always indicate restored microvascular physiology. This can lead to adequate visceral perfusion but not adequate oxygenation to the tissues. This leads to an ischemia-reperfusion injury, resulting in an aberrant immune response and end organ damage and dysfunction. This multi-system organ dysfunction is a significant cause of delayed morbidity and mortality following hemorrhagic shock. Direct peritoneal resuscitation is a method that we use at our institution that involves a hyperosmotic solution distilled into the abdomen in addition to conventional IV fluid resuscitation. This can either be continuous or intermittent, and it is a glucose-based solution that has been shown to have the most promising vasodilatory effects. The components of the direct peritoneal resuscitation that we use at our institution, it's 2.5% dextrose. It contains also sodium chloride, lactate, calcium chloride, magnesium chloride, has an osmolarity of 398 and a pH of 6.0. The vasodilatory components that we believe are the dextrose, as well as the lactate, the osmolarity, and then the pH itself. We have previously shown that DPR causes visceral vasodilation and improves intestinal and liver blood flow and decreases organ damage. More recently, we looked at the combination of fresh frozen plasma resuscitation with DPR resuscitation and found that it significantly attenuates intestinal barrier damage and dysfunction following hemorrhagic shock. With that in mind, we wanted to look at further organ damage in organ systems. So using our previously published model of hemorrhagic shock, we assigned rats to 5 different groups. 8 were in each group. Sham, which had procedures but no hemorrhagic shock. Then the 4 experimental groups, which were the crystalloid group, the DPR group, the fresh frozen plasma group, and the fresh frozen plasma plus DPR group. Looking at their central hemodynamics throughout the time, you can see that the only real difference is during the hemorrhagic shock. There are restoration of normal hemodynamic parameters throughout the rest of the resuscitative period and the 4 hours following resuscitation. Looking at effective hepatic blood flow, which we did using the galactose clearance, which is a standardization process and is known to correlate with effective hepatic blood flow, we found that crystalloid, DPR, and the combination of FFP plus DPR all restored hepatic blood flow within 30 minutes of the resuscitation period. FFP actually took a little bit longer to restore blood flow, but did result in a sustained increase in blood flow. Crystalloid resuscitation, as expected and as we had previously shown, resulted initially in an increase, but then a progressive decline and persistent lower levels of blood flow throughout 4 hours post-resuscitation. So we also then looked at different serum markers that are evidence of organ damage, and the fatty acid binding proteins are known to be an intracellular protein that is released into the serum once there is cellular apoptosis. So FABP1 is one that is a known marker for the liver. And in looking at this, we found that, as expected again, that crystalloid resuscitation resulted in the most damage, followed by DPR, interestingly, and then FFP and FFP plus DPR both resulted in similar levels of organ damage. Then looking at the histology, you can see that there in the crystalloid group there is shrinking of the sinusoids, and the rest of the groups you have kind of maintenance of the hepatocyte architecture. Looking at enterocyte injury is also a common theme, and so we used, again, fatty acid binding proteins 2 and 6 to delineate this. And again, crystalloid resuscitation resulted in significant more damage to the intestine, and specifically FABP2 is for generalized intestinal cells, whereas FABP6 is more localized to the ileum. And again, DPR and FFP plus DPR and FFP alone all resulted in decreased injury. This is also denoted in the histology. Using a known grading system, we looked at the various methods and H&E staining and determined that only FFP plus DPR resulted into similar levels as sham, whereas crystalloid resuscitation DPR and FFP alone all resulted in injury at the histologic level. We also wanted to look at cardiac injury, and fatty acid binding protein 3 is not as necessarily used as much clinically, but is used in more laboratory studies and has been found to correlate with the amount of cardiac damage following an ischemic event. And when it has been shown clinically that it actually correlates with morbidity and mortality following ischemia injury. And we found here that crystalloid resuscitation again resulted in the most damage, and then DPR was significantly lower than crystalloid, but FFP plus DPR was significantly lower than all of the groups. So we looked at the FABP3, but also wanted to look at more clinically relevant markers and markers that people use on a regular basis. So we looked at the troponins as well, and again determined the same trend, that crystalloid resuscitation resulted in the most damage. DPR was lower than crystalloid, however, FFP and FFP plus DPR resulted in significantly less damage. Looking at lung histology, we examined the effects on different groups, and you can see that there's more congestion and more edema in the crystalloid resuscitation group, and FFP plus DPR resulted in the most preserved architecture, decreased hemorrhage within the alveoli, and decreased edema. Finally, we also looked at tissue edema, and as we have known that DPR does decrease some of this, and determined that, again, crystalloid resuscitation does result in significant tissue edema at the cellular level, and FFP and FFP plus DPR resulted in significantly lower in the tissues than crystalloid. So in conclusion, as we have previously shown, crystalloid resuscitation results in visceral organ injury and decreased hepatic perfusion. The various methods, DPR, FFP, and FFP plus DPR, improve and stabilize hepatic blood flow following hemorrhagic shock. FFP and DPR together have shown to mitigate organ injury and may be a novel adjunctive method to decreasing ischemia reperfusion injury and organ damage following hemorrhagic shock.
I've asked the invited discussants who are here to come to the podium, and Dr. Jean Moore, I'm sure, will have cogent comments.
Good job. I congratulate Dr. Shuck for her excellent presentation, and commend Dr. Smith for expanding on the summer work of Dr. Garrison, who introduced DPR more than 2 decades ago. This is clearly a Louisville innovation, a legacy of Dr. Polk and the late Dr. Richardson. Today, the authors propose that using plasma instead of crystalloid resuscitation enhances the benefit of DPR. Experimentally, and in many cases proven clinically, DPR is beneficial in diverse scenarios from enterocolitis to organ donation. But I will confine my remarks to trauma and more specifically to elucidating the mechanisms and applicability of this rodent model to the critically injured patient. As I understand, the dominant mechanism of DPR, as nicely shown in the presentation, is enhanced abdominal visceral perfusion and reduced edema with secondary distant organ effects. The perfusion solution, as presented, is a 2.5% dextrose with an osmolality of 398 and a pH somewhere between 5.5 and 6. What effect does this system have on systemic osmolarity, glucose level, and pH? Could this dialysate remove reperfusion bioactive products from ischemic viscera? Have you measured these biomediators in the peritoneal effluent? On the other hand, dialysis can remove beneficial proteins. What is the effect of DPR on local and systemic hemostatic capacity? Have you investigated the opportunity of modifying this 2.5% defect solution since you've used it over the last 25 years? Of course, I realize in Kentucky, you want to stay with a winning horse. Finally, some might argue this hemorrhagic model is a bit contrived. As you know, modern resuscitation for post-injury hemorrhagic shock is now accomplished with balanced blood products and more recently whole blood. In fact, much of the benefit of DPR in this model is achieved through a reduction of edema. Furthermore, your model tests the impact of DPR at the time of initial fluid resuscitation. How do you envision this being done in the emergency department, and again, with the potential adverse effects on hemostasis? Have you conducted experiments, for example, that include uncontrolled liver or splenic bleeding? Your biomarker and histologic data are convincing, although I'm somewhat confused about the hepatic blood flow with plasma. What is the organ functional results from your study, particularly ones you measured such as bilirubin and INR for liver and creatinine for kidney? In sum, I congratulate the Louisville Trauma Group for their landmark innovative concept in optimizing resuscitation of the critically injured patient. Thank you.
Thank you, Dr. Shunk. We'll close. The senior author is unavailable, unfortunately. But I'm assured that Dr. Shunk can do this very well.
Thank you, sir. Thank you, Dr. Moore, for your commentary. I appreciate it. So when looking at initially, we have monitored various different solutions, kind of whether the 2.5, we initially started with the 4.5% solution and a mannitol-based solution that has morphed over the years, and the 2.5% solution has been the most effective and been found to have the most vasodilatory effects. Other groups across the country and in various parts of the world have actually looked at pyruvate-containing solutions and found beneficial things with that, but they do not have as much data and have used it as much as we frequently have. When discussing whether the solution has an effect on the systemic osmolarity, glucose level, and pH, we have found that it does not. All of our tests have shown that the blood work does not change from the DPR group versus the other groups on osmolarity, pH, or blood glucose levels. The question regarding whether we were removing bioactive products and bioactive mediators from the group in the peritoneal effluent, that is an excellent question. We have actually thought about looking at that. In some initial studies, we have found that the biologic makeup of the visceral lymph and the DPR effluent that has been used are very different, but it is something we are looking forward to looking at later. And with the effect on the hemostatic capacity, we have not specifically looked at coagulation profiles or things like that, and I think that that is an important aspect of going forward as we are now using a lot more hemostatic resuscitation than when we initially started using DPR. The actual benefit, and if there may be a benefit at a cellular level, but if there is a benefit in mortality and actual morbidity following hemorrhagic shock. And then finally, looking at whether we have looked at levels of the creatinine, ALT and AST, and bilirubin. And interestingly, there is a decrease in the ALT and AST, but the other organ functions, there is not a different level in those lab values following DPR versus FFP, crystalloid, or the combination of them.
Okay, I'm impressed. Next, Dr. Lafiti from Valhalla.
Thank you very much. Rifat Latifi from Valhalla, New York. I just got up to give a comment and tell you that I really feel guilty for not using it for the last 20 years. God knows I left many abdomens open, both for trauma and acute care surgery. But now is a standard of care in our institution. We just gonna report next week our first 30 patients. And it really works in some of those pretty sick patients that probably would have died. We measured Apache score and a physiology score, and they both significantly drop down by the time you end up the DPR. So keep up the good work, and we use your protocol, actually.
Thank you.
Thank you.
And Dr. Turkovich from
Circulate Sacramento. I recognize, of course, that the study you presented here, quite nicely, by the way, is a rat model. But there are, as Rafit alluded to, there are ongoing clinical investigations of the use of this or similar solutions in human. A frustration I think we've had with attempting to use it is so many of the abdominal trauma patients are left with an open abdomen for 1 or 2 or 3 or 4 or 5 days with some type of wound vac on it. I wonder if you could comment on its use in that setting.
So that is actually, thank you, that was a very excellent question, sir. That is what we have been doing in our clinical scenarios. So we use it mostly, and that's where we implement it, is with open abdomens. And so during the procedure, there is a catheter that's placed over the mesentery, as well as a drainage catheter that is placed. And there have been, we use our own kind of makeshift wound vac at Louisville, but there have been reports of using the Abthera to drain this solution. And then that solution runs with an initial bolus of 800 cc's an hour, and then 800 cc's, and then 400 cc's an hour following that until the second take-back operation. And our initial clinical data showed that we have decreased time to abdominal closure and actually a decreased hernia rate at 6 months following this, as well as decreased intra-abdominal complications using that in an open abdomen scenario.
I don't see anyone else at the microphone. I congratulate you on a beautifully presented and discussed paper.
Thank you, sir.
Our next presentation is going to be virtual and is entitled Reviewing Patient-Reported Outcomes 1 year following liver transplantation. The presenter is Dr. Ola Ahmed, MD.
Deliver this talk at the 2021 Western Surgical Association annual meeting on behalf of the Division of Abdominal Organ Transplantation from Washington University School of Medicine in St. Louis. The title of this talk is Reviewing Patient-Reported Outcome 1 year following liver transplantation. Although clinical practice is largely based on objective physician-measured morbidity and mortality outcomes, reports about functioning and well-being or health-related quality of life are equally important outcomes in healthcare. There is, however, a gap in long-term patient-centered data that can be used to predict meaningful outcomes. Clinicians are therefore limited in their ability to accurately counsel patients regarding the relevant risks, and specific concerns relating to what their lives may look like after surgery may remain unaddressed. Patient-reported outcome measures can be used to obtain self-reported information about an individual's function, be it physical, mental, or social health, and such measures may stand alone as the sole measure of a concept, or they may complement clinician assessments and other performance-based measures. There are several existing questionnaires that were often considered the gold standard for a particular concept or domain relating to health-related quality of life. Most are familiar with the short form 36, which is a 36-item questionnaire measuring 8 scales. This can help generate a short form index that's scored from 0 to 1, and this can in turn be used in the assessment of quality-adjusted life years. The brief pain inventory form uses scores of 0 to 10 to measure how pain has interfered with 7 daily activities. There's also the Health Assessment Questionnaire Disability Index, consisting of 8 sections with 2 to 3 questions per section using scores of 0 to 3. The EU Quality of Life form is another instrument which evaluates the generic quality of life, and the Health Utilities Index is a rating scale used to measure general health status and health-related quality of life years. Although there's no shortage of templates to use for quality of life assessments in clinical practice, all of these tools have some limitations. There are differences in the ranges of domains covered per instrument. Each instrument uses a different individual metric, making comparisons between questionnaires difficult. In some instances, you see large proportions of respondents scoring at the very top or the very bottom of the scale in some populations, creating a ceiling effect in the very healthy and a floor effect in the very unwell. Some questions are difficult to understand, especially if language barriers exist. In the clinical outcomes literature, many modified versions of these questionnaires are used depending on the target population, and these modifications result in concerns about comparability. This brings us to the Patient-Reported Outcomes Measurement Information System that was developed by the NIH with the purpose of providing standardized resources for use in clinical research and practice, and centralizing the development and collection of patient-reported outcomes by addressing some of these problematic issues. These validated tools are based on a tripartite framework of physical, mental, and social domains that are important to patients. To bring this back to our experience, liver transplantation is an exemplar model of complex surgery and can be associated with significant morbidity and short and long-term challenges to functional recovery and quality of life. This leaves many patients wondering what their daily lives might look like after surgery. And as such, this study aimed to report global health-related quality of life at 3, 6, and 12 months in liver transplant recipients using standardized PROMIS profiles. The analysis included all adult recipients of liver transplantation who reached 3, 6, and 12 months post-operatively. Patient-reported quality of life data was collated using the PROMIS 29 profile to assess 7 healthcare domains using a total of 29 questions with 4 items per domain. The survey was administered via phone calls, and responses to each question were captured using Likert-type answer sets. Broadly speaking, PROMIS tools use a T-score metric in which 50 is the mean of a relevant reference population and 10 is the standard deviation of that population. In this context, the reference population is the general US population, and so a score of 40 is 1 standard deviation lower than the mean, and a score of 60 is 1 standard deviation higher than the mean. The higher the score, the more of a concept an individual has. So for example, a physical function T-score of 70 can be viewed positively. However, an anxiety T-score of 70 is a concerning finding. For the purpose of this particular study, responses were reported as poor, fair, good, very good, or excellent in relation to the population reference. Out of a total of 255 liver transplant recipients, 175 were successfully contacted and participated in the study, giving us a 68% response rate. There was a slight male preponderance, and the median age for the study was 59 years, with a median MELD score of 23. Overall, mean PROMIS scores were all marginally lower than the mean population reference, and there were no major differences regarding overall PROMIS measured quality of life scores in our cohort during the 12-month follow-up. One of the first observations was that physical function was the lowest domain in the immediate 3-month post-operative period. And this corresponded with pain scores, which were highest at 3 months. On further analysis of physical health, 22% of liver transplant recipients demonstrated poor physical function scores by 3 months. However, this improved by 12 months, where only 8% had persistently poor PROMIS scores. Overall, there was a clinically significant improvement in physical function during the studied period. Important improvements in pain scores were also observed post-operatively. By 3 months, 41% of patients demonstrated excellent pain scores, increasing to 59% of recipients by 12 months. During the same time period, 48% of liver transplant recipients scored fair or poor pain scores, and this decreased to 22% of recipients by 12 months. Broadly speaking, fatigue scores improved between 3 and 12 months post-operatively. On further analysis, the frequency of patients with excellent fatigue scores initially increased from 34% to 44% between 3 and 6 months, decreasing again to 39% of recipients by 12 months. The final measured physical health domain was sleep impairment. Mean scores remained largely unchanged. However, in the immediate 3-month post-operative period, 15% of liver transplant recipients reported poor or fair sleep disturbance scores, which gradually increased to 21% and 19% of patients by 6 and 12 months. When we looked at mental health domains, liver transplant recipients reported lower mental health scores when compared to the general population score of 50, and this indicated slightly better mental health in this patient population. Although anxiety scores remained largely unchanged, worsening impairment was observed by 12 months, where 12% of recipients had poor or fair anxiety scores compared to only 6% of recipients at 3 months post-op. Mean depression scores remained grossly unchanged, and the frequency of patients scoring excellent scores increased from 72% at 3 months to 81% at 12 months. Finally, social health was determined by assessing recipient satisfaction with participation in social roles. Remarkably, our liver transplant recipient cohort demonstrated higher and healthier scores than the general population at 3 months, 6 months, and 12 months. Over 85% of patients demonstrated excellent social health scores at each time point, and this increased to 90% of recipients by 1 year. To conclude, liver transplantation remains a valuable and necessary intervention to treat patients with end-stage liver disease, and the present study provides an insight into multiple health-related quality-of-life domains that are critical to overall patient well-being, using PROMIS instruments which provide a universal language. Physical health improves remarkably post-transplant, although some impairments in mental health warrant further analysis. Promising social health scores can help dispel the perception that liver transplant recipients are limited in their social roles and alleviate concerns regarding social well-being post-operatively. These data can help capture the true effectiveness of liver transplantation and inform patients of the short and long-term effects of surgery, while also help identify gaps in functional status. Thank you for the opportunity to deliver this presentation.
Our invited discussant is Dr. Rosen. Dr. Rosen, would you mind coming to the podium to give your remarks? Appreciate it.
I'd like to thank the authors for this study for addressing such an important topic. As surgeons, we treat patients with two aims: to help them live as long as possible and to help them live the best quality of life. In other words, to add life to their years and years to their lives. It's easy to assess survival, which is the focus of most of our studies and publications. Assessing quality of life is much more difficult, but equally important. Dr. Ahmed and her colleagues at Washington University have shown us that the use of the Patient-Reported Outcomes Measurement Information System, or PROMIS, is an excellent tool to assess quality of life. This study will serve to set a new standard on how we should study quality of life, not just after liver transplantation, but after all operations. I have 3 questions. The first, have you found differences in scores based on disease, severity of illness, or presentation? I'd be interested to know whether or not scores vary with different diagnoses, malignant versus non-malignant disease, patients with and without addiction, MELD scores at the time of transplantation, or acute versus chronic presentations. Second, your findings have the potential to improve treatment of patients after transplantation. Do you intend to do that, and if so, how? And third, if you were to measure PROMIS scores prior to transplantation, do you think that individual patient scores could potentially improve patient selection? Are you planning to do that? And if so, do you think the pre-transplant scores could trigger intervention intended to improve results after transplantation? Thank you.
Thank you, Dr. Rosen. Dr. Doyle will serve as closer for this paper.
Thank you, Dr. Rosen, for those comments. And I'd just like to thank Dr. Ahmed for her work in putting this together. She couldn't be here. She was very excited to come to the meeting, but unfortunately the US is still blocking travel from Ireland until today. So I'm happy to discuss this and address some of these questions. So this was really our first delve into using PROMIS in our transplant population. And so we haven't as yet kind of gone into the details with regard to MELD and the other patient factors such as disease, opiate addiction, that sort of stuff. I think these are hugely important, and in our next tranche, when we start looking at this really prospectively going forward, we plan to look at all of these details and stratify the patients in more detail. I think it's very important to consider that a patient with a high MELD may well have a poorer outcome post-transplant. However, the high MELD patients often tend to get the best livers, and so you have patients who are coming for liver transplantation who have a lot of chronic problems, and they may end up in many ways having worse outcomes. And patients who develop complications post-transplant, who may have a low MELD beforehand, may well develop, have more issues post-transplant. So I think it'll help trend our post-op recovery pathways and plans for these patients afterwards. Now, even with this small study and without the stratification that we've talked about above, we still have found a lot of opportunities in the patients that we really didn't realize, particularly in the mental domains of the PROMIS data. Sleep disturbance and anxiety are one of the biggest things that we actually see getting worse over the 12-month period, not getting better. And so in answer to your second question, we are planning not only to have physical function pathways for recovery, but also to really focus on mental function after transplant. This is something that we have certainly done very poorly and is difficult to achieve for patients, but an area that we really want to focus on. And then for your third question, so the pre-transplant data, we certainly plan to collect pre-transplant data, and our plan going forward is to collect data pre-transplant and then at the time periods post-transplant. I don't think we would necessarily use it as a selection tool for patients as to whether or not they would undergo transplant, but certainly the opportunity, as you suggested, Dr. Rosen, to consider patients for prehabilitation in the various different domains, I think is hugely beneficial. We have developed at WashU are developing a very robust prehab for patients, and this is within all aspects for all surgeries, I should say, not just for transplant, but it's mostly based on physical function, so thinking about fragility scores and those kind of things. And I think we have a huge opportunity to focus on some of the mental health and the other social aspects to really improve patient outcomes. I also think PROMIS, because it's standardized to the US population, gives us kind of for the first time a picture of where our post-transplant patients stand in relation to the population, and they're clearly doing quite well, but still we have more opportunity to set expectations for these patients pre-transplant based on the data collection. And then I think by setting expectations for the patients, we can improve their satisfaction post-outcome, because I think it's been demonstrated certainly by having the right expectations, you'll probably have a better or more satisfying outcome than thinking that you're going to achieve something that you may not post-operatively. So thank you again for the questions. Happy to take any others.
Are there any further questions? Yes, Dr. Talamini.
Thank you, Dr. Doyle. I always enjoy the presentations from your group in St. Louis. In terms of patient-reported outcomes, there have been some reports that post-operatively, mid-level provider clinics, those run by advanced nurse practitioners or physician's assistants, can really improve the recovery of those patients from the simple act of just being able to call and communicate with them, so they diagnose when patients are having psychologic and physiologic problems sooner than waiting for those post-operative visits. And I wonder if at your institution you've invested economically and conceptually in the use of mid-level providers as a way to improve patient-reported outcomes.
Thank you for the question. I think it's a hugely important, they're hugely important personnel to help drive this forward. We, for our post-transplant patients, we mainly have nurse coordinators who are the main go-between the patients. I will say one of our most recent recruits in the mid-level field came from another institution where they had all mid-levels managing the patients post, and according to her, the patient satisfaction levels are very good based on that. So I agree, it's an investment, but it's also a worthwhile one. In addition, we have put into play across the department, in one of my other roles in the department, where we're instigating calls and connecting with patients within 48 hours after surgery, wherever possible, to try to potentially allay fears, reduce readmissions, and allay fears of patients or concerns, address concerns that they may have post-operatively. So I think all of these things, preemptively contacting patients and staying in close touch with patients, helps lead to better patient satisfaction and better outcomes.
Okay, thank you, Dr. Doyle.
Thank you.
And that brings us to the final paper of this session, entitled Disparities in the Transport of Critically Injured Patients to Trauma Centers, an Analysis of the National EMS Information System, presented by none other than Dr. Cherise Berry.
Thank you, Dr. Hughes. I'd like to first thank the Western Surgical Association for the opportunity to present our work and for the privilege of the podium. We have no disclosures. So unintentional injury is the leading cause of death for Americans aged 1 to 44. When patients are critically injured, rapid assessment, scene time stabilization, and transport to verified trauma centers for definitive care are really essential in achieving zero preventable deaths. And studies estimate that about 20% of civilian deaths are potentially survivable. That works out to be about 40,000 lives per year. So the National Academy of Science, Engineering, and Medicine report really describe a national movement to achieve zero preventable deaths after injury and minimize disability, really by creating a national trauma system. And so the CDC field triage criteria were developed by the ACS Committee on Trauma and the National Highway Traffic Safety Administration, really to provide a standardized approach for EMS to recognize seriously injured patients and who would then benefit from being transported to a verified trauma center. And so this standardized approach is really based on physiology and anatomy of the injury and mechanism of injury, and then consideration of special populations. But it really mandates that these patients are transferred to a verified trauma center. And so we know that patient morbidity and mortality really decrease when injured patients meeting CDC field triage criteria are transported by EMS directly to verified trauma centers. And so while previous studies have demonstrated a marked survival benefit when injured patients are transported to trauma centers versus non-trauma centers, there really has been no study that has evaluated the factors that influence the decision to transport injured patients to trauma centers. So the objective of this study was to identify potential disparities in the transport of critically injured patients to designated trauma centers. This is a retrospective review of the National EMS Information System, or NIMSIS, from January 2018 to December 2019. Using data from the National Association of EMS State Officials East Region, which comprises about 12 states plus Washington, D.C., with a final transport destination that was recorded. So patients with an injury and a final acuity designated by EMS as critical or emergent were included, and patients who were found dead on the scene had a final acuity as low, or patients with missing data were excluded. So here are cohorts. So we looked at critically emergently injured patients, and from there looked at two subgroups. So a CDC field triage subgroup, so those patients who were designated by EMS as meeting field triage criteria, and then a physiologic subgroup, so those patients with unstable vital signs. So GCS less than 13, systolic blood pressure at less than 90. And then we determined, where did these patients go? Did they go to a trauma center or did they go to a non-trauma center? And that was based on zip code data. And then we collected data on demographics, injury type, vital signs, EMS response, scene time, transport time, and then the reason for EMS deciding where to transport this patient. We then compared the cohorts between trauma center versus non-trauma center using t-test and chi-square test, and then looked at a multivariable logistic regression analysis to determine the association of demographics and other factors on the transport to a verified trauma center. And so in looking at the 2018-2019 NIMSIS data, pulling out those patients from the East region, that was about 5 million patients. When we then filtered out patients that were injured, that came to about 672,000 patients. When we then took out the low acuity patients, dead on the scene or missing data, we then had our cohort of critical or emergent patients. That was about 94,000 patients. And then there's two subgroups, again, those meeting CDC field triage criteria, it was about 30,000 patients. And those that had unstable vital signs, our physiologic subgroup, was about 15,000 patients. And so here are our results. So women were about 41,000, men were 52,000, women were a little bit older. When you look at the race data, 26% of the patients were Caucasian. You notice that almost 62% was marked as other or unknown, and that's because this is not self-identified data. This is identified by EMS. 28% of the patients were insured, slightly higher among women. What we found interesting is that for critically injured patients, 44% were taken to non-trauma centers. And then of the patients that met CDC field triage criteria, about 58%. Of those, 23% were taken to non-trauma centers. And for physiologic and anatomic criteria, about 54% of the patients, and still about 25% were taken to non-trauma centers. The reason, closest facility, and about 44%. And then the reason listed as other for 36.5%. So on logistic regression analysis, women were 19% less likely to be transferred to a trauma center if they were critically injured. And if they were critically injured with unstable vital signs, they were 26% less likely to be transported to a trauma center. And so there are limitations. So with any database study, the accuracy and availability of the data really relies on voluntarily reported data. EMS judgment on what constitutes a life-threatening injury may not be accurate or may be overstated in their reporting. Patient outcome data, so morbidity and mortality, were not available for this study. Because of data usage agreements between NEMSIS and individual trauma centers, we were really unable to utilize geospatial coordinates to accurately identify trauma centers, and so we had to rely on zip code data. There was an overlap in about 20% of the trauma centers and non-trauma centers, but we did a sensitivity analysis and where those that overlapped were removed, but the results held. And finally, race, ethnicity, and gender data were not based on self-identification, but rather EMS identification. So that goes to the accuracy of the race and ethnicity data. There could be misidentification of patient race or gender as unknown or other. It also goes to the misgendering of patients. However, despite the limitations, it's the largest study to date demonstrating an association between gender disparities in the transport of critically injured trauma patients to trauma centers, despite the availability of standardized national field triage guidelines. And so the key findings, right, 44% of critically injured patients are not being transported to trauma centers by EMS. 23% of critically injured patients designated as meeting CDC field triage criteria are not being transported to trauma centers by EMS. 25% of critically injured patients with unstable vital signs are not being transported to trauma centers by EMS. And critically injured women were 19% less likely to be taken to a trauma center compared to critically injured males. And critically injured women with unstable vital signs were 26% less likely to be taken to a trauma center compared to critically injured men with unstable vital signs. So really it's a call to action For PI processes that assess EMS compliance with field triage guidelines, we really need to implement processes to ensure that critically injured patients, all of them, are transported to verified trauma centers. We need to implement processes aimed to eliminate sex-based disparities in the transport of critically injured trauma patients to verified trauma centers. And we really need access to EMS pre-hospital data at the local, regional, state, and national level for transparency and accountability, so that we can ensure that the standards of trauma care are being met and health equity is achieved for all patients. Thank you.
Our invited discussant for this paper is Dr. Dan Margulies, who is making his way to the podium.
Thank you, Dr. Hughes. Given the proximity, temporal proximity of this discussion to lunch, I will not restate any of the study. I will say that this is the first report that I have seen on noting the gender difference in transport. And I congratulate the authors on investigating the topic and for an excellent presentation. My first question is, what do you think is the cause of this disparity? The implication behind this statistically significant disparity is that there is some bias present, either implicit or explicit. If so, what would that bias be? That is, why would females be less likely to be transported to a trauma center? As you think about that answer, note that you list the reason for a destination other than a trauma center was more commonly patient or family choice for the female patient. And could that have any role in this decision? Secondly, of those meeting CDC field triage criteria, although you found a difference between gender being transported, it ended up being a difference of 11%. And although an important difference, I am also struck by the large number overall, that is 43%, who were also not taken to a trauma center. Do you have any idea why such a large portion did not get transported? And also, how does that compare with other mature trauma systems? It seems remarkably high. And parenthetically, when I looked in our area, we saw maybe 15%. Lastly, although the gender difference you highlight is new information and important, I also noticed that race was an even more significant difference, with white patients less likely to go to a trauma center, and conversely, presumably non-white patients more likely. Do you have any insight on the reason for this difference? And in thinking about that, could there be other factors that might explain both results, which might be missing from the regression analysis? My thanks to the Western Surgical Association for allowing me to discuss this paper, and to the authors for providing it in a timely manner.
Great. Thank you, Dr. Margulies, for those excellent questions. To address, why are we seeing this disparity? I think it's really difficult to know the answer to that question right now. Until we have a fundamental understanding of the processes involved in transporting critically injured patients at the local, regional, state, and national level, we're not going to know the reasons why we're seeing disparities at the level of gender. To address the issue of, is this bias? It could be. There's been previously reported data to support disparities in the transport of women to trauma centers. This is the largest, and we focused in on critically injured patients, but there could be. But again, we really need to understand the process at each of those levels. I think regarding the large finding of 44% of the 92,000 critically injured patients not being transported to a trauma center, and that's a huge problem. We know that patient morbidity and mortality are improved when patients are transported to a verified trauma center. So really having a fundamental understanding and knowledge of why, the CDC field triage criteria are standard criteria. We should be taking these patients to the nearest verified trauma center, so why that's not happening, again, more questions to answer. Regarding the finding of race, I think I really wanted to focus in on that because that was part of the limitation of this study. 61% was identified as other or unknown. And so when you have race being identified that's not self-identified, it's kind of hard to really draw any conclusions from that. But I think we really have an opportunity to, this call to action that we really need access to this data. There are a lot of data usage agreements with NEMSIS where you can't look at the data state by state. You have to look at it in multiple states or by region. And so that really gets to how do you determine opportunities for improvement if you can't see or analyze the data per each state. I think we have an opportunity also to look at how do we revise how we're collecting this data so that we are truly collecting accurate data. And finally, I think, again, the opportunity to implement policies at the national level for standardization of how we transport our critically injured trauma patients. So this is just the beginning of this work.
Thank you, Dr. Berry. Dr. Wren?
I'd like to congratulate you. That was an incredible work, and I think really is surprising that so few are being transported to trauma centers. I think it's shocking, and your call to action is should be widely heard. I wonder if the college would be taking this up. The bias issue about gender is very interesting. If you look at percutaneous coronary interventions, it has been so well documented, not just in the United States, but other places, that even when it's known that the woman is having an acute coronary event, they get less interventions and everything. So there's numerous examples of sort of, I don't know what, almost discounting women's illness. And I will really look forward to your future work to see if you can sort out what's driving this. So thank you.
Thank you, Dr. Wren.
Dr. Moore?
A very nice presentation, but as you alluded to, this is literally the tip of the iceberg. Since our glorious no preventable deaths came out from NEMSIS, as you know, the mortality for trauma has increased every year since that report. We are failing in the United States. We do not have a national trauma system. It's regionally dictated, and unfortunately, in many cases, just like us in our hospital environment, is driven by economics. EMS is one part of it, but I wonder if you had an opportunity with a database, and unfortunately large databases don't have a granularity, to look at regions where this really occurred more often and why that was. Were there integrated health systems that demanded transfer to non-trauma centers? And the other aspect in our country, as you well know, there's no regulation of air transport. Have you looked into that? Because I would bet that's even more egregious than ground. Congratulations on your provocative work.
Thank you, Dr. Moore. I think you raise an excellent point. It's access to the data. I was literally on a phone call this morning with our state, really asking for our state data to really address this issue. And there's not a process in place currently in the year 2021 to be able to access this data for analysis without it then going through the approval process, the red tape, the you have to get approval before you can disclose it. I mean, none of this should be happening in 2021 when we need to really establish best practices for our patients. I think you mentioned the air travel. That's something that we can look into as well. But again, this is just the beginning now that we have identified where the issue and where the problem is.
Dr. Jerkovich?
Dr. Jerkovich, Sacramento. Congratulate you, of course, for bringing forward this topic. Thank the program committee for that. You've heard a lot of discussions around the issues that have to do with the lack of accountability in the EMS pre-hospital setting for the steps they take to provide care. Very few EMS systems are truly linked to a quality review system, to the hospital care, to the post-care discharge. They have a total different system of how they're run, whether it's by the fire departments or local EMS directors. They're just not standardized. I'll put that comment aside for a second. Let me just close with this. If you could add 1 or 2 questions to the NEMSIS questionnaire that would get at the issues of why are you ignoring the field triage guidelines, what questions would you ask? Are the donuts better at Hospital B? Is the parking places better there? Did the patients decide to go there? What questions would you put on there, assuming you'd get an honest answer, but what would you like to know?
Thank you, Dr. Dvorkovich. I would honestly say, on that questionnaire, I would say, you have identified a critically injured patient. Here is the local level 1 trauma center. I want you to explain to me why you would not take this patient to a verified trauma center. Explain your reasoning. And I would leave it open-ended like that. And that goes to the heart of accountability.
Thank you, Dr. Berry, and congratulations. And this ends the session.
Great.
Appreciate y'all, and see you at lunch with the lawyers.